Welcome to the deep dive. Today we're taking quite an intensive look at something really fundamental. What happens when your sense of self, your core identity, is systematically challenged by aging, illness, and, well, the institutional care environment?
Yeah, we're really digging into Chapter 11 from basic geriatric nursing. It's all about self-perception and self-concept.
And our mission really is to translate these pretty essential psychological concepts into knowledge you can actually use.
Exactly. We need to understand not just how self-worth can erode, but also what are the crucial clinical interventions? What can we do to help older adults maintain their dignity and, importantly, control?
Okay, so let's start right at the foundation. Self-identity. If we sort of boil it down,
Mhm.
it's how you see your own abilities, your self-worth, your overall self-image, right?
That's it. And the chapter is clear this identity is forged by basically three things: your personal values, your life experiences over time, and the feedback you get from the world around you.
Ah, the feedback. That sounds like where the problems can start.
It often is.
Yeah.
Ideally, self-worth should be tied to your internal values, what you've achieved, who you are inside. But there's this relentless pressure, isn't there,
Mm-hmm.
to measure ourselves against these external standards, often pretty artificial ones.
Yeah, we're talking about those societal ideals. You
Yeah.
gotta be young, thin, rich, successful, independent, all of it.
Right. And for older adults, as physical changes inevitably happen, relying on that kind of external validation, well, it can be devastating.
So the research actually shows self-esteem declining.
It does, yeah. It shows a decline in old age, and particularly for the very old.
Mm-hmm.
It's because they're constantly measured or measuring themselves against those, frankly, unrealistic external benchmarks.
That makes sense.
And we really have to acknowledge some unique vulnerabilities here, too.
Like what?
Well, the chapter brings up a really powerful point about older adults in the LGBTQ plus population.
Mm-hmm.
They often carry this incredibly heavy burden.
That's up.
The fear of discrimination or even outright mistreatment in care settings or from peers, it can force them to hide who they are, their identity.
Oh, wow.
And that increases social isolation, and it can critically lower their self-esteem, especially late in life when support is so needed.
That environment, all that judgment, that loss of validation, it sounds exhausting.
It is. And it brings us right to this huge psychological task of late life. Erikson defined it as maintaining ego integrity versus despair.
Ego integrity versus despair. That sounds like a pretty heavy psychological lift. What does that mean in practical terms for our listeners?
Well, think of it as the ultimate life review. Success means looking back and being able to conclude, okay, my life had value, it had merit. You get this sense of wholeness, serenity. That's integrity.
And the alternative.
Failure, that leads to feelings of regret, bitterness,
Mm.
worthlessness,
Hmm.
despair.
So what determines success or failure in that stage?
The chapter points to several factors:
Mm-hmm.
your general attitude, your history of self-esteem throughout life, the emotional support system you have, and really fundamentally, your ability to maintain some sense of control over your own life.
But society seems to constantly undermine that integrity, doesn't it? Through ageism.
Absolutely. The chapter actually calls ageism the most socially condoned form of prejudice in the U.S. It's everywhere.
Constantly painting older adults as, what, physically and mentally inept, dependent, non-productive.
Exactly. And here's the really insidious part, the feedback loop. Older people who actually accept these negative stereotypes, they suffer worse health outcomes.
Wait, really? Believing it makes it physically worse.
Yes. Worse health outcomes than those who consciously reject those stereotypes. Your internal self-concept, what you believe about yourself as an older person, literally influences your physical well-being.
Wow. Okay, so if self-concept is like armor, then aging and illness are these constant attacks. The cumulative effect of physical decline must be just crushing.
It really is. And it's not just the big things, the major illnesses. It's the daily, sometimes silent erosion of self-respect.
How so?
Well, the sources stress that some of the deepest damage to self-esteem comes from losing control over things we take completely for granted, like easy movement or being able to manage going to the bathroom independently. Elimination.
Things you don't even think about until you can't do them.
Precisely. And that fundamental loss of autonomy, it kicks off this cluster of deeply negative feelings that often feed into each other. Depression, powerlessness, helplessness, hopelessness, fear, and anxiety. It's a vicious cycle.
And these physical issues are happening alongside all the other losses common in late life, right?
Exactly. It compounds. You've got the death of spouses, friends, family members, the loss of independence, maybe giving up driving, the stripping away of social roles like retiring from a career, and just the general decline in physical health or even mental agility for some. It's a
Yeah.
lot of loss to process.
This seems like it leads directly into the challenge of social isolation.
It's a huge factor.
Hmm.
The book talks about the concept of the elder orphan.
Elder orphan.
Yeah, older individuals who are isolated, maybe with no known family or very few social connections to provide support. It's a stark reality for many.
And the pandemic must have just amplified that isolation terribly.
Terribly. It really underscored that chronic loneliness isn't just sad, emotionally painful. It has real negative physical effects. It contributes to things like hypertension and increased rates of heart disease.
So when that isolation transitions into needing institutional care, like a nursing home, does the damage to self-concept get worse?
It often accelerates, unfortunately. An institutional setting, even a good one, can inadvertently strip away visible identity. You lose your home, most of your possessions accumulated over a lifetime, often reduced to what fits in a small dresser or nightstand.
Losing your things, the symbols of your life and history.
And maybe even more critically, you often lose control over your entire daily schedule.
Wait.
When a facility dictates exactly when you eat, when you bathe, when you sleep, it's almost always based on the convenience of the staff schedules, the care provider, not the individual's lifelong habits or wishes. That kind of regimentation is a direct assault on dignity.
And I imagine if the move to a skilled nursing facility wasn't entirely their choice, maybe they felt pushed into it.
Exactly. If they weren't included in that planning process, older adults often interpret it as rejection. They feel isolated, like they've just been put away.
Which must deepen those feelings of powerlessness and despair.
Absolutely. Which brings us to a vital point for clinical practice, for nursing. How do we actually reverse this institutional powerlessness?
This can be done.
The chapter really emphasizes this. The essential nursing action is helping the older adult feel valued and, crucially, helping them maintain control wherever possible.
So the intervention isn't about, say, fixing their physical problems necessarily, but more about restoring their sense of agency, their choice.
Precisely. Offering choices, even seemingly small ones. What outfit to wear today, what time they'd prefer to bathe, which meal option they want. It's vital for reversing that feeling of powerlessness.
Does it really make that much difference?
The sources say yes, absolutely. Offering choice might take a little longer in the short term, coordinating preferences, but the evidence shows it dramatically reduces long-term resistance, agitation, and it really improves self-esteem.
And personalizing their environment, does that help too?
Oh, definitely key. Encouraging family to bring in pictures, mementos, things that reflect their history. It allows staff to recognize the resident not just as the patient in room 3B, but as an individual with a unique story.
Like, oh, that's Mrs. Jones, she was a noted gymnast, or that's Mr. Smith, he's a decorated WWII veteran.
Exactly. It acknowledges their past and their personhood.
Okay, before we dive fully into interventions, there seems to be this massive elephant in the room the chapter highlights: untreated depression.
Yes, it's a huge issue. In long-term care settings, the prevalence is estimated as high as 78%.
Wait, hang on. 78%. That's staggering. In some facilities, that's nearly 4 out of 5 residents potentially struggling with depression.
It's incredibly high.
Yeah.
And yet, the chapter notes the majority of these cases are missed. They go untreated.
Why? Why is the failure to diagnose so high when the prevalence is that massive?
A big reason is that depression in older adults often presents atypically. It doesn't always look like the textbook definition we expect.
How so?
Well, the classic signs we might look for in younger people, like significant weight loss, major sleep changes, decreased energy, these are often dismissed in older adults,
Dismiss as what? Just part of getting old.
or as symptoms of their other underlying medical disorders, which are common in this population. It's much easier, perhaps, to blame a thyroid issue or chronic pain or medication side effects than it is to diagnose depression.
That's interesting. The chapter also mentions that depression can be directly linked to specific medical conditions, right? Like hypothyroidism or anemia.
Yes, and even to some commonly prescribed medications. Things like certain antihypertensives, some heart medications like cardiac glycosides, or even certain types of analgesics, painkillers.
So care providers need to be really vigilant about side effects for every drug.
Absolutely. And look beyond just typical sadness. The National Institute of Mental Health identifies other key warning signs healthcare workers need to watch for.
Like what? What are those signs?
Things like chronic irritability or unexplained anger, obsessing over minor physical complaints or problems, trouble concentrating or making decisions, difficulty carrying out normal daily activities, persisting for weeks, and a real loss of interest in hobbies or activities they once enjoyed.
That cluster of symptoms, it sounds like it feeds directly into the most critical risk the chapter discusses: suicide.
It does. The statistics are deeply concerning. Older adults account for about 18% of suicides in the U.S., which is disproportionately high compared to their percentage of the population.
And is there a specific profile for who is most at risk?
Tragically, yes. The risk profile is quite specific according to the text. White men over the age of 85, particularly those with a history of what are called affective disorders, basically mood disorders like depression or bipolar disorder, they represent the highest risk group,
And the outcomes of attempts.
are horrifyingly lethal. The completion rate is drastically high, something like 1 death for every 4 attempts among older adults, compared to maybe 1 in 20 for the general population.
Why such a high completion rate?
It's often because they tend to use more lethal means, and also they are less likely than younger people to communicate their intentions verbally beforehand. They might not say, "I want to end my life."
So the clues might be more subtle.
Much more subtle. Instead of talking about it, they might present to doctors or nurses shortly before an attempt with vague physical complaints that don't seem to have a clear cause.
What else? One of those critical, subtle clues.
Things like suddenly giving away prized possessions, unexpected or rapid weight loss when there's no other explanation, maybe suddenly revising a will or taking care of other end-of-life administrative tasks. These are all serious warning signs that demand immediate attention and intervention.
Okay, let's shift towards assessment then. For nurses, what are the concrete, observable signs they should look for when someone's self-perception might be altered or damaged?
Well, physically, they should look for visible posture changes. Are they slumped over, withdrawn, sort of defensive looking? Are they avoiding eye contact? And listen to their language. Are they making negative self-statements like, "I can't do anything right" or "I'm useless"?
Any clinical signs?
Yes, clinically, you might actually see signs of the autonomic nervous system being stimulated. Things like an increased pulse rate, maybe elevated blood pressure or diaphoresis, that's excessive sweating. These can all indicate profound underlying anxiety or distress.
So once you've identified someone struggling, say, with altered body image, maybe after a stroke or an amputation, what are the goals of care?
The chapter outlines specific goals. Ideally, you want the patient to eventually be able to look at and even touch the affected body area, to verbalize their concerns about it openly, and importantly, to identify their personal strengths, focusing on what they can still do.
And the interventions to reach those goals.
First and foremost, establish a non-judgmental, trusting relationship. That's foundational. Then, consistently focus your interactions and care on their abilities, not fixating on their disabilities.
That makes sense. What about nonverbal things?
A really powerful nonverbal intervention is assisting with grooming and clothing selection. But the key here, the book stresses, is making sure the person looks appropriate for their age, which preserves dignity,
As opposed to.
as opposed to trying to make them look cute, which can feel infantilizing and undermine their self-respect. It's about dignity. And coordinating rehabilitative care carefully is also vital.
Now, one of the most important coping strategies the chapter identifies, especially for reaching that state of ego integrity we talked about, is reminiscence, life review. How does that translate into actual care?
Reminiscence isn't just idle storytelling. It's described as a vital coping mechanism. It actually helps the individual resolve old conflicts, maybe work through previous problems or regrets, and ultimately come to that conclusion that their life has had value and merit.
So it's the vehicle that leads to that sense of serenity, that integrity.
Exactly. And implementing it can be quite simple. Encourage individual reminiscence or maybe group sessions. Use triggers, old photographs, familiar music from their past. Even just open-ended statements like, "Tell me about when you started your family," or "What was it like growing up then?"
Does it work?
The evidence cited suggests it does. It benefits patients by decreasing anxiety. And interestingly, it even shows benefits for the nurses involved, increasing their job satisfaction by connecting with the residents' histories.
Okay, what about managing fear and anxiety? The book distinguishes between them.
Yeah.
Right.
Yes, it makes a clear distinction. Fear is described as specific dread related to an identifiable source, like a fear of falling during transfers, a fear of crime, or a fear of pain during a procedure.
So interventions need to target that specific source.
Precisely. Provide opportunities to express those specific fears. Take steps to reduce the source of fear, like being extra careful and communicative during transfers. And thoroughly explain all care procedures beforehand to mitigate that fear of the unknown.
And anxiety is different.
Yes, Anxiety is defined as more vague, maybe an unidentifiable dread or apprehension. It's not tied to one specific thing.
So the interventions are different too.
Right. For anxiety, the focus is more on reducing overall stimulation, providing a quiet, calm environment, encouraging them to verbalize those vague thoughts and feelings, and using distraction techniques can be very helpful. Things like crafts, maybe knitting, listening to soothing music.
Finally, let's touch on interventions for hopelessness and that feeling of powerlessness. Hopelessness sounds particularly dangerous.
It is. The chapter defines it as feeling unable to solve problems, seeing no alternatives, no way out. And it notes that this feeling correlates most closely with those highest suicide rates we discussed, especially among the very old, 85 and older.
Which means building trust is absolutely critical.
Paramount. Frequent visits that aren't just about direct care tasks, just stopping by to chat for a few minutes, are essential to build that trust. And nurses must be actively assessing for passive suicidal behaviors,
Passive behaviors like what?
like consistently refusing food or necessary medications. It might not be an active attempt, but it's a form of giving up that needs immediate attention.
And then directly countering that feeling of powerlessness, what are the tangible strategies?
They need to be concrete and consistently enforced. Allow older adults to make choices whenever possible. Menu items, clothing, activities, timing. Encourage self-care, even very small tasks like washing their own face or combing their hair. Every bit of independence counts.
What about the environment?
Adapt the environment for maximum independence. Maybe an elevated toilet seat makes things easier, ensuring necessary items like tissues, water, call bell are always within easy reach. Explaining the reasons clearly for any changes in their care plan is also vital.
And avoiding being overprotective.
Yes, the source material warns strongly against this. Avoid being overprotective or overbearing. Crucially, avoid redoing what the person has already accomplished, even if it's not perfect,
Why is that so bad?
because it strips their dignity. It reinforces that feeling of being incapable or childlike. You provide help only to the extent needed. Let them do what they can.
And the final, maybe ultimate intervention against powerlessness.
Respecting their rights. The chapter is very clear. Nurses must respect the right of alert, mentally capable older adults to refuse care, even if the nurse disagrees with the decision. That right to refuse is the ultimate act of self-assertion, and it's critical for maintaining self-concept.
Wow. This deep dive really shows just how central self-concept is. It's like the core psychological battlefield in geriatric care, isn't it? Constantly under challenge from loss, from illness, from ageism.
Absolutely. And it highlights that the nursing role is profoundly emotional. It's
Yeah.
about providing support, yes, but also actively using tools like reminiscence. And maybe above all, maximizing personal choice and control to help that older adult retain ownership over their valued life story.
Indeed. We've really seen how much damage can be caused, often unintentionally, when individual identity gets stripped away, maybe for the convenience of the system or the schedule.
The constant tension.
So perhaps we can leave you, our listener, with this thought to mull over. Considering the real-world pressures and necessary efficiencies of modern care settings, how can you, in your role or even just in your interactions, ensure that the unique identity and the self-assertion of every individual are genuinely prioritized? Prioritized over, say, the operational needs or the convenience of the provider.
How do we really keep the person, and not just the patient or the resident, visible and central?
That's the challenge. Thank you for joining us for this really essential deep dive into the human experience of aging and self-concept.
We truly appreciate your dedication to learning and for being part of our little last-minute lecture family.
Catch you next time.